you for the lovely introduction. Thank you KMA and Astrada for inviting me here today and giving me this opportunity. And thank you the previous speakers for excellent talks. I think a couple of weeks back, Kodolika sir gave me a call saying, "Tu yeshi ka Kolhapur like CME organize करायची." And I said yes. The only thing that I heard was Kolhapur and KMA because there is a special relation that I have with this particular place. My father served as a president and secretary of this very organization in late 90s, and as a kid I used to come here very frequently. It's 20 years from that time that I come here as today's speaker, so it makes a special occasion for me. Now, the thing that Kodolika sir told me that we are supposed to talk about the problems a transplant surgeon faces, and so many things, and I was confused about exactly what to talk about. There's a list of things starting with the morbidity and mortality of the patients, from the pre-operative optimization, from the lack of organs, the poor organ pool, from the ADLTs, LDLTs, intraoperative problems, unique situation, post-operative, including the problems that the surgeon faces with no family time, hobbies, and no social life. Don't worry, I will not be talking about this today, but there's a list of things. So I have decided that I will restrict my talk only to the surgical aspects, intraoperative aspects, and if you want to stop me at any point, please do. So before beginning, there are two things that I want to talk about. First is today's date, that is 13th of August, that is World Organ Donation Day. And there are two slides, two numbers only, and I want all of you to take a good look at these two numbers. I don't think I need to say anything after that about the organ donation thing. Now, this is the number of the people who require liver transplants each year. Now, the data that I have used here is from 2019 and 2020, because that was the year I was presenting the first article for Indian Journal of Transplantation for expanding the donor pool. So, the figures can change in the last 2 years, but you can get an idea from this. The first thing is number of patients requiring liver transplants in India each year ranges somewhere between 50,000 to 1 lakh. And the actual number of transplants that we are performing each year is somewhere between 500 to 1,000. Just take a look at these numbers. We are actually performing only 1 to 2% of the transplants, and rest 98 to 99% of the patients are not even being offered the services of transplants. And the second number that comes is the organ donation rate in India, which is 0.08 PMP, and PMP here stands for per million population. So 0.08 per million, that is 0.8 per 10 million, that is 8 donations for 100 million people. And we are the country of 140 crores. Now, the second slide that I want you to take a look at. One healthy cadaveric donor can donate 1 heart, 2 lungs, 1 liver, which can be split into 2, 1 pancreas, 2 kidneys, small bowel. Same donor can also donate bone grafts, skin, and cornea. So practically you can save 8 lives and help other 50 people. So 58 lives you can impact. On an average, Indian family has 3 to 4 members. I will count it as 4. So 48 or 60 into 4 is more than 240 or 250. So one good cadaveric donor or one organ donation can practically impact 250 lives. That is the importance of today's day, the World Organ Donation Day. So these are the two numbers that I wanted you to take a good look at. Now, something that we must appreciate and encourage, the city of Kolhapur and Kolhapur Medical Association have always been very active towards these organ donation programs. We have a good number of organ donations in the last few years, one of the highest in the state. There are many cities in this state where there has been not a single organ donation. We have seen a good number. In fact, I remember my first outside Pune city retrieval surgery, somewhere in 2018, was here at Aster only. A 25 years guy dancing in his friend's marriage ceremony, fell down, had a head injury, and the family decided to go for the donation. That was my first outside Pune independent retrieval as a surgeon back in 2018. And Aster Radha has been one of the torch bearers in this field of organ transplantation, and we must applaud this thing. Last year, in the month of April 2020, the Aster Radha Hospital performed city's first liver transplant. So they do deserve a round of applause. Now, coming to the core of the topic, what are the challenges the transplant surgeons face? Difficult roads will lead to beautiful destinations, and smooth seas do not make skillful sailors. So we are not supposed to be afraid of these challenges, we must face them. So I have divided the challenges in these broad categories. Pre-operative issues, intraoperative, post-operative, special scenarios like APO incompatible transplants, swab transplant, pediatric liver transplants, minimal access transplants. People have started doing laparoscopic, not only donor, but laparoscopic liver recipient surgeries as well. Then teamwork and issues related to Indian scenarios. Many of the topics have already been covered by the previous speakers, so I will not be touching those things. I will restrict myself to the surgical issues. As far as pre-transplant workup, already Amol sir and rest of the people have discussed. I will just highlight few points that I want to stress upon. By the time these patients reach to the tertiary care centers, be the Aster Radha Hospital or at my center as Sahyadri Hospital, Pune, they already are very morbid. They have gone through multiple decompensations, repeated admissions, repeated bleeding episodes, tappings, and they come to us in a very weak state. What we say in liver transplants is sicker is the patient at the time of transplant, poorer is going to be the outcome and longer is going to be the recovery period. So earlier we decide and push them for the transplant, we are going to have better results. Now, after multiple decompensation, one factor that has been missed by many of the people is the severity of sarcopenia. Sarcopenia is an independent marker for post-operative recovery. So these patients usually come with zero muscle reserve, they are poorly marked, they are very malnourished. So their post-op recovery, the early post-transplant period is marked with longer hospital stay, catching of infections. So we prefer patients to be treated in a pre-transplant period where they are not only optimized from liver point of view, but also from the nutrition point of view and by improving their performance status. Because these two are very important factors as far as recipient recovery and longevity is concerned. Third thing comes is antibiotic resistant sepsis. Even the ceftazidime, avibactam, PAD resistant organisms are now there in pre-transplant patients and post-transplant. Once you get these organisms in a post-transplant setting, you are helpless. You are literally helpless. So we must be very careful while prescribing antibiotics in a pre-transplant setting. Always follow the culture and sensitivity protocols and do not push them to the level that we won't have any antibiotics left for next 10 years when the patients will come with these kind of infections. Performance status, cardiac and pulmonary reserve, I have already spoken. And as far as severity of portal hypertension and coagulopathy is concerned, we will come to that when we see the intraoperative pictures. Now, 3-4 points which are usually missed from hepatology perspective in a pre-transplant setting. Number one is AKI, HRS, CKD spectrum. We have been taught about the HRS definitions, type 1, type 2, AKI, HRS, all those concepts are gone now. It comes under one single entity called as AKI, HRS, CKD spectrum. By definition, HRS is something that we have been taught that there are no long-term effects or there is no structural change. That is not true. Recurrent episodes of AKI, HRS will lead to non-AKI HRS and then into HRS CKD. If this continues in these patients may end up into simultaneous liver kidney transplants rather than only liver transplant. So we should not take HRS AKI lightly. Why HRS AKI? Because it is the commonest decompensation we face in our liver patients. The next two are not the commonest, but the most deadliest one. The recurrent hepatic encephalopathy and hepatic hydrothorax. 2 episodes of any of these, we should think about transplant within 3 months, otherwise the mortality in these patients is exceptionally high. Third thing, hyponatremia. Any sodium level below 125, it's an independent marker of long-term survival. That was the reason the model for end-stage liver disease or the MELD score that we use as a baseline was changed from MELD to sodium MELD. And one small quick fact, this score that has been universally used for all liver patients has been designed by an Indian doctor only, named by Dr. Patrick Kamath. And now that MELD in last year has changed to MELD 3.0, where apart from the other parameters of MELD, they have included albumin as well. And again highlighting the importance of nutritional and status and muscle mass in these patients. Sarcopenia, I have already spoken about. Antibiotics, I have already spoken about. Now coming down to the surgical aspect. Medical aspect, I think already has been covered. There are three parts broadly. One is the cadaveric donor. Already people have discussed about it. I will go into the surgical part. And then living donor and recipient. Now cadaveric donor, the problem is availability. In Pune we have seen the waiting time ranging between 6 months to 2.5 years. The wait list mortality of a liver patient is around 40 to 50%. Patients are there on waiting list and 50% of them will die because they do not get the cadaveric organ. Renal friends have option of dialysis. We do not have any such options. Once the liver starts failing in a CLD patient, only thing that can save him is new liver and nothing else. Second is donor identification. I think we already had an entire topic on this, and donor maintenance as well, so I won't go in there. The donor surgery especially becomes challenging or difficult when it is about a simultaneous multivisceral retrieval. There are people who are taking heart, there's a team from lung, even from abdomen there are people taking pancreas, liver and kidneys, and that is where it becomes something challenging. This is the actual picture while we were doing the retrieval. You can see the laparotomy ranges from xiphoid up to pubic symphysis. The entire bowel has to be rotated and you have to expose the whole length of IVC and aorta. Then you cannulate the aorta at the infrarenal location, and then you open the chest. Now the problems that we face or the challenges in this surgery, first is intraoperative donor maintenance. These donors will crash while shifting from ICU to OT or inside the theatre the moment you open abdomen, or even more commonly when you open the chest. So intraoperative donor maintenance is very important. We need a good anesthetist there. That is the same thing I have written again, the donor crashing. We have had donors which were crashed while shifting from ICU to OT. We literally had to jump on that bed and open the abdomen right there and put the cannula in the aorta, because if you don't perfuse the organs with the solution, those organs are going to go waste. It is more of like an immediate cardiac death after donation rather than brain death donation. The third thing that problem comes is the doubtful organ or marginal organ. Now, it's my own article in Indian Journal of Transplantation regarding the expanding the pool of the organs. Whenever you are in doubt, we go for frozen section, we get some of the information, but we should not reject the organs, especially when it comes to liver, just because you see that it's a mild fatty liver or something. The last year's data, and the people have used even hepatitis B and C positive livers who have gone through liver trauma, grade 3 liver trauma livers have also been used provided there is no biliary leak, and they function nicely. Hepatitis B, C positive cadaveric donors is no longer contraindication. Second thing, another thing that I want to tell you about the intensivist regarding the sepsis. Culture positive donor is not a contraindication for organ donation. If the antibiotic sensitivity is there, if you are given the antibiotics for 48 hours, you can take that liver. You can take that organ. Procalcitonin high doesn't make it as a contraindication. Now, anatomical variations when it comes to surgical part of it. We will have at least 30% of the patients when the hepatic arteries are aberrant. When the right hepatic artery is arising from SMA. So while you are mobilizing the liver, if you just go on dissecting, you will end up injuring the inflow of liver. So you have to always check about the aberrant vessel anatomy before mobilizing the liver, be it right hepatic artery arising from SMA or there is an independent supply for the left lobe of the liver. Then another problem comes when you are given short length of vessels, when there is a multi-organ retrieval. When you take heart, they also require suprahepatic IVC. We as liver surgeons also require suprahepatic IVC. This heart is 3 centimeters length thing. So we have to cut it and make between so that even heart team gets adequate vessel length and even we get adequate vessel length. Similar thing happens when you take pancreas. Because they require portal vein, we also require portal vein. So there you will have to make changes accordingly to the recipient surgery where we get adequate lengths for the anastomosis and the recipient doesn't land up into problems. And then you have surgical mishaps and cold ischemia time. We have already spoken about it, it has to be less than 7 hours, and surgical mishaps do happen while transportation, while taking out the organ falls down, while transportation, the bag is not adequately insulated and the organ gets damaged. You can see the liver being cracked while transporting. So these are the things which happen. So these are the challenges we face. From there we come to the living donor. I'll talk about recipient later. As it has already been spoken by multiple people that the donor safety is the most important thing. There are many patients for whom I have evaluated more than 7-8 donors, rejecting all previous ones, saying that if I will not take even 1% of the risk for the donor morbidity or mortality, even if your recipient is dying. Because that itself goes against the basic principle of living donor transplants, be it any organ. That donor cannot be compromised in any way for some benefit that recipient might get. So we do more workup, more investigations for the donor than recipient to check the safety. And one more point Amol sir mentioned, living donor, so we don't keep them for 2 months in the hospital. We discharge on day 5 and my donors go back to their work on day 11. No restrictions, no diet restriction, no medicines, nothing. So we need to ensure that beforehand. And he has already pointed out most of the things, so I won't repeat that much. So this is the basic liver anatomy. It is divided into 8 lobes, and the transaction or the cutting part depends on the 3 vessels, that is left hepatic vein, middle hepatic and right hepatic. Usually for cadaveric transplant, you take out the whole liver and you implant it. For living donors, you divide it in the central part, somewhere here. This right lobe goes to the adult recipient, and whenever we plan for pediatric recipients, we take left lobe or only the left lateral. It depends on the recipient weight. The basic criteria for this is the weight of the graft has to be at least somewhere around 0.8% of the dry weight of the recipient. So you can take even only the right posterior lobe as for transplantation, entire right, entire left, or only left lateral. And all this has been done. Now, this is the thing I was talking about. It is called a GRWR, graft recipient weight ratio. The ideal remnant is 30%. You can pull it down to 27% or 26% as well, provided the liver has 0 fat and the quality is very good. This is the actual picture of living donor mobilization. The right lobe has been mobilized. You can see the IVC. The caudate vessels directly draining into IVC are already ligated. The kidneys are down there. The adrenal has been cleaned nicely. The entire right lobe of the liver has been lifted up from the IVC, and you can see the right hepatic vein that is there, which will be looped and will be divided at the end of transaction. Now, here again, similarly to the cadaveric part, the anatomical variations play a very important role. Now, in cadaver, the only purpose is you are not supposed to injure that thing because you want to put it in recipient. Here, the responsibility is double. You don't want to divide the vessel more on the right side or even on the left side, because if you come more on right, it is the graft or the recipient who is going to have problem. If you go more on left, it is the donor who is going to land up with problems. I'll show the pictures, you will come to know what I'm trying to say. Now, once the mobilization happens, we dissect the porta. You can see the right hepatic artery. The left one goes from this side. This is the biliary division. And we temporarily clamp the inflow, the right hepatic artery and portal, so that the part of liver which is supplied by the right vasculature becomes slightly darker, and then we mark the transaction line. So this is the line we divide the liver in right donor hepatectomies. And we use CUSA or hydrogen, that's a surgeon's preference, what to use for transaction. Now what I was talking about, the vascular anatomy and the I'll be showing you now. This is the aorta, this is the celiac axis. You can see the right hepatic artery, the left hepatic artery, that is GDA going down. Now whenever we are planning a transaction line, the transaction has to go like this. And even though the scan images look like this, the actual picture, intraoperative picture is not that clear. You have to be very careful. Now here's an interesting case. If there are any radiologists, they can pick it up. This is celiac axis, this is SMA. If you can look at nicely at the celiac axis, or if I rotate that film, that donor is having critical stenosis of celiac axis. Okay, so if we take the graft, if the remnant is not supplied enough, the donor will go into post-hepatectomy failure, and that has very high mortality. So again, if you see that SMA, there is a branch from this thing SMA that is going up and actually draining into GDA. It is going posteriorly. So we took this donor because this supply was enough going into left hepatic artery, and we took the right liver, and the donor is doing fine. So these are the anatomical variations as far as hepatic artery is concerned. Now we come to the portal vein. So this is the portal vein. The right one goes with the right lobe, left on this side, and this is the point where we actually take the cut. Now here is an interesting scan. You can see the portal vein, the right posterior portal, right anterior portal, segment 4, left and left lateral. And all this division is intrahepatic. So you cannot divide this liver. So these are the donors we need to reject. So this was the rejected donor with very aberrant portal vein anatomy. This has not been described in any literature. Then comes the hepatic venous anatomy. Now, the pink part is what stays with the donor. The green is what we take with the graft. Now, this is the MHV or the middle hepatic vein that decides what line of transaction it has to do. We can take the right graft without MHV when we transact from this on the right of MHV, or we can take it on the left and we can take the outflow of segment 5 and 8 as well. Now while doing that, this is another vein that we need to remember. 30% of patients will have inferior hepatic veins. So liver drainage is going right, left, middle hepatic, and sometimes the lower segment, segment 5 or segment 7 or segment 6, will have an independent vein draining directly to the IVC. Now apart from these veins, we have to anastomose this as well. So when it comes to surgical challenges, if this vein is more than 3 mm or 5 mm, we will have to anastomose. Now the final and the most difficult part for us surgeons. Surgeons will understand that is the biliary anatomy. Because that is one organ which has maximum variations in anatomy. So that there is no abnormal or variant of biliary anatomy, we call it as a normal variant only. Because 40% of them will have normal type A1, which has right hepatic duct and left hepatic duct as described in textbooks. 60% will have different anatomies. You can see it here. This is the common bile duct. This is right posterior, the right anterior hepatic duct. The right posterior is draining into left hepatic duct, and then it is joining the rest of the biliary system. Now, if we take the cut on this side, I will get two biliary endings which are far from each other. So, two biliary anastomosis at a distance in the recipient. If I go slightly on this side, I will injure the donor remnant biliary system, and now the donor will require biliary enteric drainage. So, the anatomy for living donor still remains very crucial. Now, this is the one case of the donor that we have done. You can see what exactly it is there. It is actually the donor having two CBDs. This is the infraduodenal part. This is right CBD. This is left CBD. This is the cystic duct. This is right posterior, right anterior, and this is left. And they have another common channel here. So we divided this thing for graft at this level, and we did single biliary anastomosis in the recipient, and donor of course had two CBDs and intact biliary system. That is the importance of anatomical variation, and this is what looks at the end of donor surgery. This is the donor remnant. The right lobe has been taken without MHV. You can see the intact middle hepatic vein here. Segment 5 has been clipped, segment 8 has been clipped. This is the IVC. You can see the biliary system divided, the portal vein, this is the IVC, sorry. This is the portal stump and this is the biliary stump. Now this is the scar of the donor surgery, living donor surgery. So I call it like the scar. These are the scars that warriors beauty marks because they do it for their loved one. Then the last part comes is recipient surgery. This is an extensive thing. We can go on talking about 2 days about this, but I'll restrict myself to important points only. The recipient surgery has these basic parts. First is the explant hepatectomy, you have to remove the diseased liver entirely in total. Second is the bench surgery. Be it a cadaveric graft or living graft, you have to reconstruct it. I will talk about it in the bench. IVC anastomosis. There are 2 methods, the conventional bi-cable where you do suprahepatic anastomosis as well as intrahepatic, or a piggyback one which involves only one anastomosis. Then portal vein, then you open the clamps and reperfusion. This is the step where most mishaps happen in recipient surgery. Then there will be significant hemodynamic and cardiac changes once you open the clamps. You need a very good anesthesia and ICU team to manage these issues. Then you have to quickly do the arterial anastomosis to keep the warm ischemia time short. And then biliary anastomosis and final hemostasis. We'll go through one by one. So this is what we usually get on the recipient table. You can see the extensive portal hypertension and you can imagine the amount of bleeding if you just touch one of these vessels. They will have hernias, gross ascites, recurrent tap-ins, SBPs have got so much of adhesions and frozen aorta. So we have to face these, the surgeon faces these challenges. This is the picture not of a cirrhosis, but of an NCPF patient, but I've just taken this picture to give you an idea of the amount of collaterals we face during surgery with the patients who are having such high portal hypertension. One tiny prick into that and then it is nearly impossible to stop the bleeding. This is the actual explant when the liver has been removed. I have the picture of the recipient in further slides. Now it comes to bench surgery. Bench is when you take the graft, living or cadaver, and then prepare it for the implantation. When it comes to cadaveric grafts, you have to remove the excess tissue. In cadaver, in the cold ischemia period, you just immediately cut everything, take the diaphragm, vessels, everything with you, and then you take it on bench and remove the excess tissue. Because this excess tissue, be it cardiac tissue, diaphragm, those are highly antigenic tissues. You have to remove and clean the organ. Secondly, the retrohepatic IVC tributaries. There are multiple tiny vessels, you have to tie them because once you put the liver, there is no option of stopping any bleeding on the posterior surface of the liver. So you have to tie that on, you have to prepare the portal vein and hepatic arteries. Sometimes you have 2 hepatic arteries. So on the bench, we join those 2 hepatic arteries and create one single channel so that it becomes a single anastomosis in the recipient. And if you have caused any injuries while retrieving the organ or transporting, you have to correct the injuries on bench surgery. Then it comes to living. Now in living, the graft has been removed in a very controlled situation. But if you have taken the graft without MHD, the right anterior sector or segment 5 or segment 8 veins will require a drainage. So as to reduce the anastomosis, we put a PTFE graft and create a single channel for liver drainage. So these are any biliary leaks if there, those are to be corrected. So that happens as on the bench in a living donor surgery. So this is the typical recipient surgery, be it living or cadaver. First is the suprahepatic anastomosis. The suprahepatic IVC is anastomosed to the recipient IVC. If we are doing a conventional, you will have infrahepatic anastomosis will be the second. Third is the portal vein anastomosis, then arterial, and then we come to the biliary. Biliary can be duct to duct or biliary entry depending on the situation and the etiology of the patient. There are pediatric cases of biliary atresia, PFIC, PSC in adults where you do prophylactic biliary entry drainage because these patients will land up in long-term biliary issues. Now I think Amol sir has already spoken about piggyback versus conventional. Now in conventional you take the donor IVC with you. So you have to do 2 anastomosis. In living or in piggyback, you take only part of it. Now what happens when you are doing a conventional and you are replacing the entire IVC, you have to put a clamp on IVC and it's a complete clamp. So the renal outflow or renal drainage or the venous return that is coming from the lower part of the body is stopped for that amount of period. Now we don't use venovenous fibrosis, because of the short ischemia time. But previously they used to where the time was long. So piggyback avoids that clamping. So the patients who are facing recurrent AKIs in preoperative period, or other patients, because we introduce CNIs very early, for which we need good kidneys. Secondly, the lower limb drainage and whatever cytokines are produced by during the clamp time, all that has been reduced with piggyback, where you keep the IVC venous return intact throughout the implantation. Then the second anastomosis comes as a portal vein. Portal vein is a very stretchy vein. You can manipulate, even if you get the short length, you can stretch it and anastomose it. It will adapt to the flow and the length or the thrombus. The problem that comes is the thrombus, and most CLD patients will have thrombus. So this is the classification, the Edel's classification of portal venous thrombosis. The grade 1, grade 2 and grade 3. This is the partial PVT. This is the portal vein thrombus, which is limited to the main portal vein, but the splenic and SMB are intact. Third one reaches up to the confluence, and fourth one goes deep down into SMB or splenic vein. So 1, 2, 3 are not the issues for surgical point of view. Only the grade 4, where the thrombus is deep down the SMB, then it becomes a contraindication, because the rest of them we actually remove by doing a portal thrombectomy. You open the portal vein, put the Foley's catheter or Fogarty's or forceps, and actually remove the thrombus mechanically. And we establish the portal flow, and once we are sure that enough amount of portal flow and pressure is there, then we go ahead with the portal anastomosis. So there are multiple problems that portal anastomosis can have, but portal venous thrombus remains the most important one. Then we come to the third one, that is hepatic artery anastomosis. Many of them will have calcified recipient arteries, short length while taking the graft. Cadaveric organ you can take from celiac axis, the artery, hepatic artery, proper celiac, even aorta can be taken. But when it comes to living donor, you never know how much length of artery you are going to get. Secondly, there are many recipients who are post-intervention recipients. They have undergone transarterial chemoembolization. Those are damaged arteries. Their intima is not good. Sometimes the flow is not enough. So all these cases you have to go for jump grafts. You take jump grafts from hepatic artery proper, or celiac, or supraceliac aorta, or from infrarenal aorta, and those grafts are joined with the graft hepatic artery. Second thing, you can use GDA flow, gastroduodenal artery flow, or people have used gastroepiploic arteries. They remove it from momentum and reverse their direction and use them as an inflow supply for liver. Then comes the last challenge, that is bile ducts. Now, surgeons will understand what I mean by decoy strictures or duct or bubble. This is always the question. So, size discrepancies, see, portal vein will dilate. For hepatic artery, you will take a tangential cut and increase the diameter. Those things have very limited scope as far as bile duct is concerned. There are no grafts available for bile ducts. So if you are short in length, you can put a graft into it. So there are some techniques which are used for biliary anastomosis, or we can go for a bowel thing. The reason for this is most morbidities in the long-term post-transplant patients are related either with biliary or strictures. Despite whichever method you use, continuous, interrupted suturing, posterior layer continuous, anterior interrupted, PDS, Prolene, 6O, 5O, no matter what you use, you will have these problems, and these patients, if leak, they will require drainage or reanastomosis, or biliary entry, or stricture, they will keep on requiring ERCPs and stenting. So this still remains a problem for liver transplants. Now, final thing comes under the size discrepancy of the graft. As I already told you, the GRWR has to be 0.8. So, sometimes the liver is small for the recipient. This doesn't happen in cadaveric transplant, this is for liver, because cadaveric you get the whole liver. So, for small for size transplants, when you don't either, portal flow is much more for the size of the liver, we have to do additional methods which includes splenic artery ligation or a partial portocable shunting on table. And the other problem comes is large for size. This usually comes with the pediatric recipients, that even the left lateral rope or single segment is bigger for that bachchu who is 6 months or 7 months. One, because of the size is 4 times bigger, or second thing is the size of volume is adequate, but we cannot close the abdomen because the graft is that big for the kid. There we have to do the horizontal transaction of the graft and reduce the size. So that is another challenge. And we have done this recently. Post-op care, I don't think I need to go into this because it will become extensive presentation. So I will leave that part. Special situations, ABI incompatible transplants, we did one in the March. Swap, that is two pairs of donors and recipient. When the blood group is not matching with my donor, so I take liver from the donor of the other couple and my donor gives liver to that recipient. We have done that too. It requires too much of legal paperwork, but that has been done. Minimal access, we have started doing laparoscopic liver resections, but yet to do the laparoscopic liver donor, but we will be doing this by the end of this year, and maybe next year we will try for laparoscopic liver recipient as well. And pediatrics I have already spoken. But all this trouble, all these challenges are worth for when you see your recipient healthy, happy and smiling and ready to live a normal life again. This is Divya, 11 months old. We transplanted her in the month of May. This was the picture taken in June 3rd week. She is the case of tyrosinemia type 1. The liver that I showed you, the explanted liver, was her cirrhotic liver. And this is her after 3 weeks of liver transplant. And it is at the end of the day, it's a teamwork. You can see the entire team, myself, Dr. Vipin Vibhute, Dr. Manish Pathak, Dr. Manoj Rao. It's a team of 40 people that works actually for our transplant unit. It's not a job of one person. And before I conclude, I just want to say two things. Transplant is not the fear. Transplant is not the end of life. Rather, transplant is the new beginning. And the last line, we must thank all organ donors, be living or cadaveric. Gods and mothers give you the gift of your first life, but organ donors are no less than gods as they provide you with the gift of second life. Thank you.